Here comes the second piece of the puzzle, the office assessment tool. Now, this is for physicians, and this is recommended to be used in an outpatient setting. So this takes a lot longer than the SCAT, and it has some differences. We're supposed to do a very comprehensive assessment of the neck. We're also supposed to look at orthostatics, eyes, balance, cognitive tests, as well as graded exertion tests. Now, the SCOT says that you can pick and choose to do what you think is most important in your situation. But the minimal components take approximately 30 to 45 minutes to perform, and all of the components can take up to an hour and a half. Now, I don't know how I'm supposed to fit this assessment in the 15-minute time period that I have between patients. And you also kind of need to remember that we also have to write a progress note, because without that progress note, we don't get reimbursement. So whoever designed this clearly did not have a clear understanding of how most physicians see patients. However, this is a very comprehensive assessment. It is considered the gold standard, and the physician will be able to identify a concussion 99.9% of the time. Hence, this is considered as a diagnostic tool, whereas the SCAT is only considered as a screening tool. But at the end of the day, it only helps us make the exact same decision. Are there any red flags? Should I send this patient to neurosurgery or not? Or the main thing that this is used for, does this athlete currently have a concussion? Yes or no? If they don't currently have a concussion, then it's either that they never had a concussion to begin with, or technically they may have already recovered from their concussion by the time they saw me without any residual deficits. So in these situations, when the patient is perfectly fine, I can't even suspect that there may have been concussive head injury, we clear them to begin the final stages of the return to play protocol on the spot, and only tell them to come back to us if there's an issue. However, if we do diagnose a concussion, then we start treating the underlying symptom generators as needed. And we see the patient in a week and make the exact same decision. Is this patient recovered? Yes or no? So most of the times, we only see a patient for a total of 2 to 3 times. But if they're not recovering, then typically physicians will only see patients weekly for the first 4 weeks, and then decrease the frequency to like once a month if the patient is not recovering. And then they start referring them out to specialists for further management. Now, the reason why we need to do such a comprehensive assessment is because the signs and symptoms of a concussion are so diverse, and every injury is so unique, and these signs and symptoms are so dependent on which area of the brain was affected. And it is possible for patients to actually injure multiple parts of their brain at the exact same time, since the brain like jiggles around in there like jello. So these are the most common symptom clusters of concussion. They're also called symptom profiles or subtypes in different publications, and each of them has to be treated with specific therapies, and all of these therapies can be done in parallel. So here's a summary of my book chapter on the rehabilitation of sports concussion. So every clinician has their own opinion on what should be done, and so many people disagree over every little thing. But the one thing that I suspect with a high degree of accuracy that everyone agrees on is that you should not go and bang your head when you have an active concussion. So it's because of this, we restrict our athletes from playing sports, as well as conducting other high-risk activities until we know that this concussion has recovered and they're safe to, go back into their regular lives. So strict rest is only good in the first 48 hours, and a lot of research has shown that prolonged rest after that is actually detrimental for recovery in athletes. So side by side, we also manage symptoms as needed. Like, for example, if someone has headaches, we give Tylenol or Aleve. If a patient is having a hard time sleeping, then we give, guidance to improve sleep hygiene, or we can also start melatonin, like over-the-counter medications or supplements to add on. Also, we tell our patients to avoid things that make their symptoms go worse. So for example, if someone is having eye issues and screens are giving them an issue, then we tell them to, control their screen use time. Okay. So mood symptoms are a bit difficult, okay? A lot of athletes experience anxiety, irritability, and depressive symptoms immediately after their concussion. And it's because they're concussed, they feel really bad. They're missing out on school, sports, friends, a lot of things. There is a clear cause for all of their symptoms. So for most of these athletes, these mood symptoms will actually recover as their concussion recovers, and they get back into their sport. However, if there's any suspicion that this is serious, or there's even, like some indication of self-harm, then that is something that we actually address immediately on the spot. And also, on the other hand, some athletes who actually have a pre-existing diagnosis of depression, anxiety, they actually notice that their symptoms actually have gotten a lot worse after their injury. So in these situations, we actually typically tell the patient to follow up with their psychiatrist or their therapist for further management. All right, so cognitive problems. So this is something a bit unique. So again, cognitive problems are very, very common after concussion, and you may have noticed that in the SCAT as well as the SCOT, there's a really, really big emphasis on cognitive dysfunction. Now, the thing is, most of these problems recover on their own without any specialized treatment. Okay, and only in the patients that are not recovering by like 3 to 4 weeks, this is when we have to make that decision to actually refer to a specialist for like some management. Okay, so however, if a patient is exercise intolerant or if they're having neck issues, this is something that we start treating from the get-go, from the initial assessment onwards, within from the first like 48 hours onwards. Whereas oculomotor problems and balance problems, these are things that research has actually shown that it's actually not really that beneficial to start this in the first week after their injury, because the patient is concussed, they're feeling really bad. If they start doing really aggressive oculomotor or balance rehabilitation like exercises, then this actually may actually prolong symptoms, because there's that natural recovery that happens in the first like few days. So for both of these are actually things that we recommend that people should start from the 7th day of injury onwards, if they are so persistent. So the bold ones are the ones that I'm going to be discussing in the rest of my presentation. So before I actually go over that, I just want to describe a very, very typical case. So a 15-year-old female hockey player, okay, she hit the back of her head during practice 3 days ago. This wasn't observed. It wasn't immediately reported. She probably played for another 20 minutes, without noticing any, like big change in their symptoms. They went home, were, probably didn't like feel well. And then the next day they woke up with a headache. They weren't really feeling the best. Told their parent called the school coach. The school coach told them to make an appointment with the physician, and now they're here. And from their history, they probably had a concussion from like a year ago, recovered in 2 weeks without any persisting deficits. So I'm pretty confident this patient knows what a concussion is. So in my in-person examination, this patient is currently reporting symptoms of headaches, dizziness, difficulty concentrating. I do the orthostatic intolerance test. She does not report symptoms. In my cervical exam, I do notice some suboccipital muscle tenderness on palpation, but there's no like loss of range of motion. There's no like palpable spasm. This patient experiences dizziness when I'm doing the horizontal vestibular ocular reflex, and when I do the tandem gait or the BES, again, really bad balance, has 3 missteps. And then I told my athletic trainer, I need a triple test to put them on the BCTT. Came back to me, said that this patient got up to 150 beats per minute, and specifically had to stop due to symptom worsening, and the symptom worsening is headaches. So no other problems are noted. Patient is eager to go back to sport as soon as possible. So for this patient, what should I do? So I will cover all of that stuff in the end, but first, let's talk about exercise and